Hello friends, today we are going to discuss about antenatal depression and treatment planning. I am Dr. Suresh Badadmat, Professor of Psychiatry working at NIMANS, Bangalore. In this video, I'll be discussing about important principles that needs to be followed while planning treatment of depression in pregnancy. The main reason being is any kind of medications if you give, it not only impacts the mother but also the fetus and also the outcome of the childbirth. Let's discuss those important principles. Depression affects 12 to 15% of women during their pregnancy, and it is one of the important predictor for postnatal depression. Depression in pregnancy has a direct impact on mother's health, child's health, and also the outcome of the labor. Depression during pregnancy is associated with multiple risks such as preterm birth, low birth weight, low AFGAR score, congenital malformation, infant morbidity and mortality, gestational diabetes, and hypertensive disorders. Depression in utero can also increase the risk on the offsprings, such as insecure attachment between the mother and child, childhood psychopathology, behavioral disturbances in the child, childhood emotional difficulties, and poor cognitive development. These are the various important findings have been found in studies looking at the depression in pregnancy. Now let's look into the physiological changes which occurs in pregnancy. These physiological changes need to be kept in mind before starting any medication, because not only the physiological changes has put stress on the body of the mother, the medication can also cause side effects. Pregnancy affects almost any part of the body of the woman. 50% increase in plasma volume occurs during the pregnancy. Increased fat and also altered albumin and globulin ratio. This results in either decreased plasma concentration of medication, or else because of the decreased albumin and globulin ratio, the availability of the medicines or the drugs can increase. Further, because of the increased body fat, the drug distribution can occur very fast and slow elimination can occur. Further, increased renal blood flow and also glomerular filtration rate increases. Certain medications and also pregnancy related hormonal changes can cause activation of liver enzymes, also inhibition. Hormonal changes which are well known during pregnancy, such as high level of estrogen and progesterone, decrease in FSH and LH, may also play a crucial role during pregnancy. Not only it affects pregnancy, and adding medications can also cause various changes. Increase in prolactin level and oxytocin level can also impact the outcome of childbirth. Further, pregnancy is very stressful. Hence, HPA axis can activated and increased corticosteroids or cortisols, which crosses the placenta and can affect directly on the child's brain. And hence, one need to understand not only the body changes of the mother, further, there are changes which are occurring in the brain of the child, that is the fetus. During the early part of the pregnancy, there will be proliferation of neuroectoderm, that is undifferentiated brain cells or else neuron cells. And further, migration of the neuron cells to appropriate place. Further, there will be differentiation of these neuron cells depending upon the requirement. And further, formation of innumerable connections, that is synapses, occurs. Not only that, the pruning of the connection can occur. That means the unwanted connections will be removed, wanted connections gets stronger. Further, competition among these connections, which results in selective elimination of many and stabilization of brain cells, that is pruning, is important. During this brain development, if there is depression and if there is any medications given from outside, can impact the child. Hence, pregnancy is considered as a hyperdynamic state because of the increased plasma volume, hypermetabolic because there is increased hormones, which also causes increased demand on the child, which because of the proliferation which is occurring inside the brain or else in the body of the fetus. Hypervolumic, hypercoagulable state, diabetogenic, and low vascular resistance. Most of the psychotropics which we give, especially in mother who is suffering from mental illness, the medications crosses placenta, and hence that can affect the child or the fetus. Now let's understand what are the rules of thumb while planning the treatment in pregnancy, especially with regard to mental illness. Here in this video, I'll be focusing more on depression. This was a study which was published in British Medical Journal. That is, Chisholm and Payne discussed about various rules of thumb. They have given important 6 rule of thumbs. Further, later, there are some of the rules have been added. Let's look into the rule 1. All changes to drug should be carried out before pregnancy. That means if you have planned the pregnancy, that planning can minimize the number of medications which will be given to the mother and exposure occurring onto the fetus. Not only that, one size does not fit all the patients who are pregnant and suffering from depression. Each pregnant woman should be considered different, and tailoring of the treatment should be done based on the requirement of the mother, family, spouse, and also keeping the risk and benefit on the child. So all these important factors need to be considered while planning treatment. For instance, the rule number 2 talks about pregnancy should be planned. At least 3 months period, the patient should be psychiatrically stable. That means if you are planning pregnancy in a depressed woman, for at least 3 months, the patient should be symptom-free from depression. Then only we need to plan for pregnancy. Rule number 3, use drugs that we know something about it. That means try the medications which have been there in the market for many years. Do not try new medicines. The new medicines, we do not know the data. In old medicines, you know the data, how it affects the mother, at least. However, accidental exposure of these medicines on the fetus, some case studies will be available. Hence, the rule of thumb 3 clearly says that try old medicines. Do not rely on the new medicines unless the data is available. Let's look into when we start the antidepressant, especially in mother who is suffering from depression. What are the reasons to start medications? These are the important points. If the mother is suffering from severe to moderate depression, that means there is a need for either medication or psychological treatment, such as psychotherapy. Further, one need to also consider what are the negative impact of depression both on the mother and also on the child, that is on the fetus. Not only that, you need to consider what will be the impact on the labor, that is childbirth. Other problems which include poor quality of life of the mother, sleep problem, and substance abuse in mother because of depression, poor nutritional status, poor prenatal care, postpartum depression, and various other outcomes can occur. There are some important points need to be considered for not starting the medicines. What are the possible side effects of the medication on mother and also on the child, whether it is a new medicine or the old medicine. And certain medicines such as paroxetine can cause increased risk of heart disease, especially in the child. Neonatal withdrawal syndrome or else adaptation syndrome can be seen when the child is born. Hence, one need to be very careful, and the medicines need to be taken daily. And what will be the impact once the childbirth occurs? Whether there will be neonatal adaptation syndrome occurs very fast or not need to be considered. Let's move to the rule number 4. Minimize the number of medication exposure. As much as possible, avoid the medication during pregnancy, especially in the first trimester. Suppose if the patient has pre-existing mental illness such as depression and needs to be on medication because she had repeated or recurrent depressive episode and severe depressive episode, in such a scenario, choose monotherapy. And if you want to continue medications, please do not change the medication. Any medication which has kept the patient normal, the same dosage should be considered. Avoid changing the drugs during pregnancy. The simple reason is you are going to expose the child or the fetus with the 2 drugs, which is unwanted, unwarranted. Rule number 5. Use a team approach. There should be psychiatrist, obstetrician, radiologist looking into the ultrasound. If there are any child malformation occurs, congenital malformation, pediatrician, and other mental health professionals availability is very essential. Team not only from the health team, but also involvement of the husband, family members, and other members plays a crucial role. We need to educate the stakeholders when we plan for pregnancy in person with mental illness. Rule number 6 is very essential. Many of the doctors refuse the patient who do not comply with the advice. Considering woman is under different condition, she may be coerced by her family, maybe the husband's family, or even by the husband, and her own perception of being a mother in a society. Hence, she may refuse your treatment initially, and by any chance, if there is a relapse, be supportive if the patient goes against your advice. Please give them a welcome advice. If there is any problem, please come back to me. Pregnant women may choose not to take medicine or may not take even psychotherapy. But if there is a relapse, please be very supportive, because pregnancy and childbirth is not only in our hand. It is the collective family's decision. Hence, she may not have any say with regard to medication, with regard to reproduction, or else even about the childbirth. Hence, the service provider should be very flexible, should respect the patient's autonomy, and even the outcome of autonomy you should respect, and further educate them and provide the services even though she had gone against your advice. Now, rule number 7. To consider for a patient who have become pregnant, regular follow-up with psychiatrist and obstetrician is very essential. During the first trimester and also in the second trimester, antenatal ultrasound examination, perinatal or prenatal genetic testing could be done wherever possible. It is not mandatory, but if the facilities are available, look for any congenital anomaly which can occur. Hence, you need to liaison with a radiologist who is well versed to look at the neonatal abnormalities. And also you need to educate about the medical termination of pregnancy amended in 2021 to the patient and also to the family members. If there is any teratogenesis or congenital abnormality, medical termination of pregnancy can be planned at the earliest. Rule number 8. Continuity of care after the childbirth. At least 1 year after the postpartum, after the birth of the child, the mother and child should be followed up. Use technology such as telemedicine to follow up. Many a time, a woman may not be able to come for hospital along with the child. For various reasons, it may be cultural reason, religious reason, or else access to the treatment will be very far. In such a scenario, use telemedicine so that you can continue the care with the mother. If possible, home visit is essential. Rule number 9. Prophylaxis of antidepressant should be considered whenever there is a pre-existing recurrent depression or severe depression, or else attempted suicide, family history of depression is there. In such a scenario, one need to advise for medication. Not only that, you need to educate about the benefit versus risk, and the family and the patient should take the decision of to consider medication or not. However, the treating doctor's advice should be of medications in severe and recurrent depression who is currently in pregnancy. Where are these prophylactic antidepressants should be considered? The prophylaxis of antidepressant should be considered whenever there is a past history of recurrent depression or else severe depression. If the symptoms of depression come back or relapse it is there, and this depression may affect the health of the mother, health of the fetus, and also poor weight gain, especially in the fetus, and it is directly impacting the maternal quality of life, sleep, appetite, poor prenatal care. In such a scenario, we need to advocate for medication. What are the reasons to stop antidepressants? The reason is having side effects. If the patient is on paroxetine and the patient does not want to consider to continue medication in spite of education, then you need to stop medicine. If there is a possibility of neonatal syndrome and the new data emerges, we may have to stop medication because of the side effects, because of the teratogenic effects, and also one need to pay for the drug. These are the important things we need to consider before considering prophylaxis, especially in depression, woman who is pregnant. Rule number 10. What should be the dosage of antidepressant? We need to offer the lowest possible dosage which keeps the patient away from the symptoms. The aim of the treatment is to keep the patient symptom free. But however, one need to remember there are physiological changes which occurs during pregnancy. 50% increase in plasma volume, increased in body fat, and also albumin globulin ratio may change. In such a scenario, it is very difficult to know the drug concentration in the plasma. Hence, regular follow-up is essential, and also monitor the signs and symptoms. If there is any signs and symptoms relapse, increase the dosage. Hence, frequent follow-up is advocated. What are those medicines which are considered by FDA? FDA has given 3 important categories. Level A, recommendation is based on strong evidence. Level B, recommendation is based on limited or inconsistent scientific evidence. Level C is primarily based on consensus. However, Level D is a positive teratogenic effect of the drug on the child is well established. If you look at the various antidepressants, such as serotonin reuptake inhibitors, citalopram, escitalopram, fluoxetine, fluoxamine, sertraline, and vilazodone, these are kept under the C. That means the consensus expert guideline says that we can give these medicines during pregnancy, but however, we do not have consistent positive evidence to say they are safe. However, paroxetine is kept under D. That means it is harmful to the child, especially the serious, that means cardiovascular problems are noted in paroxetine. If you look at the serotonin norepinephrine reuptake inhibitors, that is SNRI, duloxetine, desvenlafaxine, venlafaxine are again kept in C. That means expert consensus guideline recommends this. Other antidepressants like bupropion, mirtazapine, trazodone are also under the expert consensus guideline. Finally, the tricyclic antidepressant, amitriptyline and clomipramine have been placed under C, that is expert consensus guideline. However, there is no data available with regard to desipramine or else toxepine, imipramine or nortriptyline. Here, the data is very minimal. Hence, the advocating these medicines during pregnancy is questionable. To conclude, my dear friends, depression in pregnancy needs to be done as a massive education program to the population. Simple reason is 15% of the pregnant women suffer from depression. Hence, there is a need to cause increased education among the public. It is essential to carry out screening in all pregnant women with regard to depression. Although SRIs are the first line of treatment, one need to keep those principles which need to be followed when planning treatment in pregnant women. However, you need to involve all the stakeholders, that is, mother who is pregnant, family members, spouse, and other family members should be involved in decision making. Risk and benefit need to be discussed with regard to medication or else not taking medication, impact of depression on the child and the mother. These are need to be discussed, and finally decision should be respected. If the decision goes against the advice of the medical profession, do not take it personally. Respect the autonomy, because the mother may not have anything to say. It is the family who had taken the decision. In such a scenario, be flexible, support the lady, and provide treatment. Thank you very much for your valuable time. Stay safe.